Thank you for being here and sticking with us for the last day of the conference. I know there's a lot of really exciting EBSs to choose from this morning. I definitely would have been struggling if not for this one. So anyway, thank you for being here, and to those who are online and watching, perhaps as they're on their way to the airport. So thanks again for being here. We are going to be starting with each of us talking a little bit, and then we'll get into more of a panel discussion and answering questions that were submitted in advance by folks, and then also hopefully we'll be able to get to any that show up on the app. So if you have questions, feel free to do the app, although I think it's a small enough group we can probably use the mics too. So anyway, here we are. It's the most important omics of all, economics of healthcare across private, public, and not-for-profit organizations. And my name's Carrie Haverty, and we'll each do our own introduction. And I just want to start by saying, healthcare is a business, and it's a big one. And it doesn't matter what our roles are, this impacts all of us. And while many of us may wish this topic wasn't necessary, it is, and the focus today is on how things work, not why they work this way, but just how they work. And for a great dive into the effects of capitalism on the healthcare delivery, please check out the excellent high demand, on demand session that's available. I thought that was really a great one to see. The other thing is a huge topic, of course, is products and services and pricing and how each of these things are priced. That's a whole other session, which maybe we'll write up for next year. So we won't get too much into the details of how individual products are priced, but you can find a lot of facts, some depressing, some funny, some both. So we'll keep going and address all of these learning objectives. So we're going to talk about venture capital, how that's different from other types of financing, for-profit, not-for-profit, what's the difference there, publicly traded companies, how that differs from other things, key financial metrics to evaluate a company or an organization's financial health. This is, I think, relevant for a lot of folks in our community right now. And then applying all of that knowledge to your own employment situation, current or future. All right, so about me, I've touched all of these different parts of the healthcare system at some point in my career. Again, I'm Carrie Haverty. I currently work for a small venture-backed startup called MIRV. We are building an RNA-based test to predict pregnancy complications, so it's a molecular diagnostic test. But I have worked in I started my career working in safety, a net hospital, a large academic institution, a private but large health system, and then moved into more venture and then publicly funded and back to venture-backed companies. So my paychecks have been touched by all of these aspects over time. As I mentioned, I am an employee of MIRV. I don't have any financial conflicts to disclose, and I am a member of the NSGC Board of Directors. What I'm talking about today is just reflective of my own experience and opinion. All right, so here's our agenda. We'll start first with Kenny talking about our venture funding, and then Christina is gonna go into public markets. Brian's gonna hit the very light and easy, uncomplex topic of hospital finances, and then we'll do a little Q&A discussion and get into more detail. All right.
Thank you, Carrie. So my name's Kenny Wong. I'm currently working at a Series A or startup company called XCures. It's a software and data company. And I also have worked first of all, as a prenatal genetic counselor at Genzyme Genetics, which is now part of LabCorp, actually seeing patients at a maternal fetal medicine clinic where I was seeing patients employed by a lab because in return, hopefully most of the samples are being sent to the lab as well. I was then employed by UCSF Medical Center, a public nonprofit company, and then also worked at 3 startups. The first one was Counsel as an early employee, which many of you may be familiar with. That was acquired by Myriad Genetics, a public company, and then joined another software company called Genome Smart that was ultimately acquired by Ambry Genetics, which was asked to be built, incorporating a part of their care platform, and then now it XCures. In terms of conflict of interest, I am a full-time employee of XCures, but the opinions are my own. And so many of you may have heard of startups, venture capitalist firms, and so the difference in how venture capitalists work is basically what they're really trying to do is they have a hypothesis. For example, right now, generative AI is very hot in the public right now, and let's say, for example, they have an idea that I believe generative AI will really accelerate precision medicine. And hence, they likely will focus on investing in companies that are aligned with their hypothesis. And because these startup companies, by definition, a lot of times are very early, they may just have an idea, or they're still building their product, or they may have a little bit of product market fit. So what these venture capitalist firms are really doing is they're investing in this company in the belief that they will grow to something of significant value in terms of their reach in, if it's healthcare, in patients, and volume and revenue as well. And so they're investing for a piece of the pie or equity as well. And so in return, they normally have some say in terms of how the company is doing as well. It's definitely much more riskier than putting your money in the bank right now, given that it's very high interest rates. But they're hoping for a significant ROI, like multiples, like 4x of ROI or beyond. That's typically the expectation there. So they're not expecting just a 15% or 20% in return as well. And so you probably also have heard of these different series stages, seed, A, B, C, D, and it goes on depending on how big the company is as well. So basically, typically for a seed stage or pre-seed company, these are companies that are very early on. They may still be developing the product. They may still just have an idea and still trying to figure out the product market fit. And as the letters of the alphabet progresses, these companies are bigger and bigger, et cetera, et cetera. And so basically, after they get the capital, what they typically do with it, depending on the size of the company, if it's very early on, it's really used to expand. In the healthcare space, it would be R&D, research and development, or the clinical development teams as well. The team needed to build the building blocks for the product. And that's when they also have to decide, do I build versus buy? Do I build it ourselves, or are there components that I can actually buy off the shelf as well? Then as the company gets bigger and bigger, then assuming the early employees have sort of figured out which customers are interested in buying your products and services, then you also then need to invest in the growth of it with the surround sound through sales and marketing as well. So if you're interested in working at a startup, I wanted to share sort of the things I've considered, given this is my third time on doing this. Is the first thing to ask is, how fast are they growing, if at all? If they're very early, if they're very early, what is their game plan in terms of selling their products and services? Do you believe, based on your clinical experience, because we're all clinicians here, that there is something of value that will benefit patients, providers, and is this something that will get reimbursed based on today's macroeconomic climate? I'm sure that's definitely a much more top-of-mind topic as well. And so these are things that I always think about when I'm joining a company, regardless of whether it's a seed stage or beyond as well. And I think the other things to also think about is sort of what's the game plan for the company? How do they intend to grow the product? And I think especially if you're thinking about genetic test, my first startup that I joined was in the lab test space for expanded carrier screening. Like, how do they intend to get reimbursed in the short term. Many of you are familiar with CPT codes, and Brian will talk a little bit about that in his talk as well. Are they piggybacking off of existing codes? How specific are those codes in terms of related to the reimbursement of your current product? Is there any risk in the reimbursement on there if it's not specific? What's the game plan in the long term? Do they intend to create a CPT code for that in that category? So is it also sustainable? And I think that's definitely something that's, and again, on top of mind based on today's macroeconomic climate as well. And I think ultimately, where do you fit in the picture? I have a very good mentor and friend of mine that taught me very early on when I joined my first startup that you're either building the product or you're selling the product. And so in terms of your role in the company that you intend to join, in terms of the RACI motto, are you responsible, accountable, consultant informed? What is your role in the selling or building of the product? Because ultimately, if you're not responsible or accountable for these things and times are not going well, likely your job may be at risk for layoff during the layoffs when they need to consider that as well. Thank you.
Thanks so much, Kenny. I'm super excited to be here with you guys and to discuss this timely and important topic. I think it can be tempting for us to think that, oh, I'm just not a business person, but economics dictates, where capital, resources, and talent are allocated, which ultimately impacts, how the information can be delivered to whom and ultimately how we care for patients. So it's very important and it behooves us to be aware of this intersection. So I'll just, give a very brief introduction about the public markets, before we get into specific discussions. So my name is Christina Wren. My journey into genetics started when I was an undergrad at Stanford. And I'm still a relatively early career GC, but after graduate training, I began my career at an early stage genetic startup building product. So I got a front row seat into seeing what that was like. I was literally the second employee there. And also in private practice, mostly focused on reproductive medicine and for patients seeking fertility treatment. More recently, I've been focused on writing and life science investing in both public and private markets. Including, as disclosures, I'm a consultant for a hedge fund, Adaptive Capital Management, and I perform due diligence on investment and opportunities. But obviously, this presentation is not financial promotion or investment advice in any way. So let's just start with the very basics. What's the difference between a public and private company? So a publicly traded company allows anyone, not just investors at a venture capital firm, to buy and sell ownership of the company on a stock exchange. So going public is often an end game for some private companies, and that's because private investors and also employees with equity can now sell their equity for cash. So it gives, this also gives the company greater access to capital with a much broader pool of investors, since nearly anyone can now invest. But obviously, going public exposes anyone to the risk of investing in that company. So there's strict regulations and scrutiny that they have to abide by. And it takes a lot of discipline and cadence to be a public company. And there can be there's a standard set of rules that they have to abide by. These are considered so that the investors can have access to this relevant information as they're considering investing in this company. This is called GAAP, or generally accepted accounting principles. So you'll find quarterly and annual reports, audited financial statements, management presentation and analyses. These are all publicly available on the company's investors relations website. And the last piece that I'll touch on is, for private company valuations, they're often less transparent and not assessed as often, and that's because the negotiations, they often occur during each round of funding, Series A, B, C. And so the price is set infrequently. So it's difficult to know what the equity in a private company can be worth at any given point in time. But obviously for public companies, it's on a marketplace, a highly efficient one. So there can be real-time pricing fluctuations, and they need to, answer to their many shareholders, which can put pressure on their, short-term performance. But, ultimately, long-term, performance is what drives business value. So one framework that's helpful to understand is this business growth cycle. So just as humans go through different life stages, companies go through a life cycle, and basically determining what inning a company is in helps us evaluate what metrics are even relevant to look at. So this sounds basic, but there's two lines here, revenue and profit. They're different. And many people assume that if a company is unprofitable, that's automatically bad, but that's not necessarily true. Typically companies, they have different priorities depending on the stage that they're growth in. It's this constant balancing act between growth and profitability. And so for young companies that have raised venture capital, like Kenny has mentioned, they tend to lose money as they're focused on growing and scaling the business. As they, trying to prove that they actually have a product or service that people want and try to win market share quickly. But, obviously, no company can rely on raising capital to fund their unprofitable growth forever. Eventually, they need to prove that, incremental spend drives marginally more return. So then the question becomes, does the company have a predictable path to future profitability? And we're no longer talking about growth at all costs, but becoming this self-funding entity so that the company can control their destiny rather than relying on investors. Then, obviously, as a company matures, growth becomes more steady and more predictable, but may start to slow down. So then the question becomes, do they have a sustained competitive advantage going forward? This is kind of an oversimplification, but we can think about where certain business industries historically fall on the curve. As a whole, for genomics labs, it's still a nascent industry, as we know, and most genetic testing labs are unprofitable today. At some point, they do need to prove that they have a clear path to becoming profitable, especially in this economic environment where every company is feeling tremendous pressure to do so. But even in this landscape, not all of them are created the same. Like, we have to look at how the numbers are changing over time, and some are really prioritizing improving the economics and quality of their revenue growth, and some may be trending in the opposite direction. And when we look on the other side of the spectrum, for more mature companies like clinical national labs, like Quest, LabCorp, health insurers like United Health Group, hospital systems like HCA Healthcare, they're often more mature late stage phase. Many of them have operating profit, so they can use that cash that they're generating to reinvest in their business by starting new product lines, doing acquisitions, et cetera. So in terms of the cost of GCs, like where does that end up going? You can look at the income statement, and genetic counseling services, they're largely captured in operating expenses. So it's included as a personnel cost of running the business, along with other functions like research, education, outreach, sales, marketing. Sometimes a portion of the GC services are captured in the cost of goods sold, which represents the direct cost of producing a company's product or service. And we can walk through an example of a genetic testing lab and some of the strategic decisions that they may face as a business. For example, let's say the test volume and or revenue growth is slowing down, maybe because the average sales price is going down, perhaps due to changes in payer reimbursement, price reductions, or maybe even the cost per unit is going up. There's certain levers that a company can consider to reduce expenses. They can reassess their product mix by cutting lower margin specialties and focusing on higher margin, higher growth specialties. They can narrow their geographic regions, decrease operating expenses in the form of reducing workforce, as we've seen recently in office lab space. Some other things, like they can invest in reducing in how much it costs to run the test. So by improving material efficiencies and automation, becoming more vertically integrated, and maybe taper acquisitions and collaboration activities. So if we look at some of the recent earnings, yeah, many labs have indeed needed to reevaluate some of their business strategies and having to make some of these very, very tough decisions. And so just end with like on an employee's perspective, just like you're inspecting a house before buying it, it's helpful to understand the financial architecture of the business, and going forward, the story that you see unfolding for the company that you may be working for. Going back to the life cycle stage that I mentioned, for young companies, the narrative is really important. It's what drives the value, and it can be divergent depending on the narrative that you tell and can change and evolve over time. But that's because there's limited history and the focus is, what the company can do in the future. For more mature companies, it's the historical numbers that often drive the narrative, not the other way around. I won't get into like specific, technical ratios or jargon, but like some key questions that you can ask or similar things to what Kenny already mentioned, like how fast is the company's revenue growing? What factors are driving this growth potential going forward? Is the company profitable? If it's not, is it on the path to getting there or is it straying further and further away? A good proxy for that is to see if, expenses are rising faster than revenues over time. And excuse me. And other basic questions include like how much total cash does it have left? How quickly is that cash growing or depleting? Does it owe any debt? And can it meet its interest and debt repayments? And then lastly, how productive are the reinvestment efforts in the form of research and development, physical assets, or acquisitions in generating future revenue? So you can answer some of these questions yourself by looking at the earnings reports and financial statements, but you can also understand it qualitatively. What is the senior management talking about and how are they thinking about the company? Are they prioritizing revenue growth versus profitability? What are they saying in the internal meetings and also in public relations investors meetings? So I'll just keep it at that, and hopefully that was a helpful introduction, but I'll pass it on to Brian to talk about the complex world of hospital finances.
Y'all. We have 15 minutes, so I appreciate Carrie alluding to the fact and Christine alluding to the fact that you cannot talk about hospital health system finances in 15 minutes. And Carrie for this helpful addition to the title of this slide, which is not for profit, well, mostly. What I will focus on today, and what I think we can get to in a 15-minute period, is I think we can start to distinguish some of the different types of hospital health systems in the United States. And I think one area that I can help our field dive into is assessing where we're at as a nation in the status of our healthcare when talking about the United States. And I wanted to put that in here because many people who attend this conference are not based in the US, and I have no experience in hospital systems based outside of the United States. So this will really focus on US healthcare. About me, I'm from Ohio, so if you hear me lean on those O's, that would be why. And I have spent all my time in clinical practice. Originally was at Genetics Center in Southern California and have been with UT Southwestern out of Texas for the past 8 years. Outside of my work with those hospital systems, I've done work with NCCN, recently with the American Medical Association CPT group, and as a volunteer within SGC. I have no financial conflicts as they relate to this talk, but I do think that being a member of a hospital system that is owned by the state of Texas, so UT stands for the University of Texas, I am an employee of the state, gives me a insight one way or another into this system, and I have other relevant conflicts there. When we look at the US hospital system, it is I think, more diverse than what you might think from the get-go. About a fourth of hospital systems in the U.S. identify as being for-profit, with the majority being nonprofit and roughly 20% being government-owned. Government-owned tend to be the ones that you think of as like TRICARE hospital system networks, but they can also include systems like my own, where we are a state hospital system but receive some additional funding from the government for particular programs. When we think about the specific differences between these types of systems, there's a lot of overlap. The most obvious differences are in taxes that health systems have to pay, with nonprofits and government-owned typically not having to pay things like property tax and income tax regarding the institution's income. As employees, if you feel like you're being stolen from, no, you have to pay income tax as employees as a state basis. But then when we look at other lines, I really want to draw people's eyes to lines 3 and 6 in this graph, which is things like investments, marketing, and advertising. I think when I first entered the field, I wouldn't have thought that nonprofits or government hospital systems could do things like invest. Certainly when I was back with the Texas Society of Genetic Counselors, it was news to me that a nonprofit organization could get involved in investing. And this is going to be really key as I move forward in this talk, because investing is a huge source of modern income for these systems. As the description of this talk alluded to, one of the fundamental things to strip from our mind is the idea that nonprofit or government-owned means that there is no profit involved. All companies need to find, for sustainability, a threshold above their operating expenses in order to maintain as a company. You need to have a buffer so that when things don't go well in a particular year, your company doesn't fold. And you can imagine that that's particularly important for hospital systems that are helping maintain the health of the nation. And so when we say nonprofit, what we mean is what these systems have to do with that operating income over the course of the year when it exceeds the operating expenses. So in a for-profit system, when you have profit, you have a lot of flexibility in what you do with that profit. A lot of it is going to be determined by what type of for-profit you are. So if you are publicly traded, profit is often going to look like dividends to your shareholders. But if you're privately held, so maybe it's unusual for hospitals to necessarily be privately held by like a single family, but maybe by a larger organization if you're privately held, then you have a lot of flexibility in what you do with your profit. You're not beholden to shareholders, so you can invest that back in the business, you can pay it out to staff as bonuses. In a for-profit that is not beholden to shareholders, there's a lot of flexibility. As we look at what nonprofits do with excess revenue or profit, the nonprofits are going to have to reinvest that money into the business. But one mistake is thinking that that doesn't look similar to for-profits. And so one of the things I did here is, it may be small for some, but I clipped. And when we look at the structure of nonprofits, they are very similar to for-profit corporations in the United States, meaning that when we see profits in a given year, it may result in things like bonuses to staff members. It may look like reinvesting in the business in investment, meaning that that hospital system may take that money and invest it in the stock market, in property. This is particularly notable because during the pandemic and during recent housing crisis and building crisis, a lot of hospital systems use that as an opportunity to expand. They said, hey, we're seeing a low cost of property value. We're anticipating an increased need as the generation of baby boomers gets older and enters the Medicare market. We probably are going to need to anticipate having higher patient volume. volumes. And so they purchased a lot of land, buildings to anticipate that future volume. And this is critical because they were doing so based on anticipating future revenue that they would get from those populations. So this is almost like venture capitalism in that they're anticipating future markets. And several hospital systems did get involved in venture capitalism. Well, rather than purchasing property or necessarily safer investments, they invested in businesses. So hospitals now invest in startups. You may see a hospital owning a laboratory company that they're hoping will increase their service line and bring revenue into the hospital system. So we get a lot of questions about our hospital systems struggling, and you're going to see in the news, particularly as of 2022, that a lot of people say that they are. And there's a lot of reasons for this. I've definitely touched on a few. The hospital systems purchase things like land and space, anticipating that they would make a lot of revenue in recent years. And as many of us know, things like inflation in the stock market haven't gone as well as what people wanted. We also know that the types of patients largely being seen at hospitals right now don't match the patients that hospital systems were hoping would come. Hospitals really, systems, regardless of whether or not they're for-profit or nonprofit, depend largely on procedural-based revenue. So revenue that comes from surgeries and procedures being done by the hospital make more money than long stays. So we know that during COVID, there was a lot of population misunderstanding about how hospitals were raking in the dough. And the misconception there is that hospital stays, because people see those large balances in the conversations that they're having with their insurance companies on hospital stays, they think that that's the hospital system's raking in the money. Oh, I stayed and it costs $80,000 is what they billed my insurance. But when we think about the amount of effort and work that goes into hospital stays, they're incredibly time intensive on the facility use for a hospital and the staffing use for a hospital. Staff have to be there to take care of those patients. And those are some of the most important expenses that drive hospital systems. Procedures are much easier. They tend to take less time, less staff, and they tend to be in and out. So there's less overall demand on supplies. So when we think about our hospitals struggling in 2022, the answer was yes. And I added a yes, but, because hospitals are very much dependent on the state of the economy. And as we know from 2017, back when the stock market was in a place that hospital systems were very healthy with, the biggest trend and one of the most important takeaways from my section today is that hospitals have decided to diversify where their income is coming from. For all of us, one of the things that you should be aware of is that most of our hospital systems, if not all of our hospital systems, are actively involved in investment. They're investing in the stock market, they're investing in property, they're investing in long-term gains. And the reason for this is that we know that hospital systems are having to battle long-term inflation. So these are systems that know that these things are going to just continue to be problems. And the most important thing you can take away from my talk today is that we are also battling the Medicare conversion factor. And I'm so glad that someone mentioned capitalism earlier, because I do not consider our health system to be as simple as capitalism is often sold. Medicare is this incredibly interesting concept for a capitalistic society to have, because Medicare is a federally subsidized health insurance plan. But beyond the fact that it's federally subsidized and that our taxes help support the cost of Medicare, Medicare has also become a standard with which we value the healthcare system services in the United States. And so when we're showing this chart up here, what I want you to take away is that yellow section at the bottom is the Medicare conversion factor. And over 1999 to present, it has stayed roughly the same. If we adjusted the Medicare conversion factor for inflation, that is the blue bar at the top. So take that visual into what we're about to talk about, which is, what is the Medicare conversion factor? The Medicare conversion factor is a statistic that we use in pricing services as a nation for Medicare. And this is incredibly important because before Medicare entered the market, payers were often left to establish the health of services on their own. So a payer said, hey, how much should I be paying a hospital for a service? And there would be a negotiation and they'd say, well, this is how much this costs us. The hospital would say, please pay us this amount. The payer would say, well, I don't want to pay you that amount. Let's negotiate. When Medicare entered the market, Medicare had to establish a cost for the services that they were willing to pay. But inadvertently, their costs became the standard for the rest of what payers paid in the United States. And today it's very well established that Medicare is essentially the baseline of what a minimum payment should look like for nearly all services. And it's why we're not going to talk about pricing of services today, but what Medicare chooses as the price for a service is incredibly important to what the service ends up looking like getting paid for by payers. And traditionally, payers pay roughly 100 to 300% of what Medicare pays. So they do typically pay more. Most of the money going into the healthcare system is not from Medicare, but Medicare is used as a standard. So the conversion factor. The conversion factor is a particular number that Medicare provides. In 2023, the conversion factor is 33.88. And the conversion factor is multiplied by the RVU, or the relative value unit, for any particular service. So every single service, genetic counseling, a procedure that someone has like a mastectomy, gets an RVU number. And then that is further multiplied by the geographic region where the service is taking place. So you take the Medicare conversion factor, you multiply it by the intensity of the work for that service, and then you multiply it by the geographic factor. And that is the payment equation for Medicare. If we look at, I realize this is small, so I wanted to just give an example. If we look at how RVUs are then created, so how do we value things like services? They're generally valued in 3 different parts for hospital-based services. So these are not labs. These would be like genetic counseling or a procedure that someone may receive a surgery. They're valued based on provider work, so the intensity and time of the work that the provider puts forward, the cost of equipment and services that goes into that work, and then the liability insurance used to cover that work. So those are the 3 major factors that Medicare uses in considering the value of services. That becomes a number, an RVU, that many of us hear about, and that number is put onto the Medicare physician fee schedule. So it's published nationally. We then use that RVU number, like I said, with the Medicare conversion factor to generate that payment number. And so for the most commonly used E&M code that a physician might use in 2023, which is 99203, the typical payment is going to be something around $112 modified by geographic area. So conversion factor, remember that's the amount that it's being multiplied by. I showed you that graph earlier. Remember how it stayed stagnant from 1999 until present? We know that that's because of inflation. And so roughly the conversion factor hasn't changed in over 20 years. This is incredibly important because it means that what medical practices were anticipating, their budgets looking like, what the health system was anticipating, they assumed that it would match inflation, and it really hasn't. And so this has driven hospitals and health systems towards finding other aspects of revenue that they can pull in. And so they've turned to the stock market, they've turned it to investments because healthcare isn't as profitable as it once was. And so you can see how this looks is that many smaller practices have folded. If you look at the number of family medicine practices in the United States, they're often being folded into larger health systems. And the practices that are doing really well are small private surgery practices that really just focus on procedures. And it's because of that Medicare conversion factor not having been increased. Why doesn't it get increased? Well, because every new service that we add has to come out of the same pool of money that Medicare has to begin with. It's a federally budgeted plan, so it has to meet the budget. when Medicare anticipates that they're not going to meet the budget, they have to do a review of the conversion factor and they have to reduce it so that they don't exceed their budget. And so when I comment on how we call this capitalism, but it doesn't function the way capitalism does if we use this as a meter for our healthcare system at large. And so that all sounds really like perilous. But it's important to know that the budget can be expanded for Medicare. And so as we talk about future for hospital systems and justifying value, one of the most important things is that societies like the American Medical Association and other medical societies often lobby for increased Medicare spending. And doing so helps us address that Medicare conversion factor. So you probably noticed that in that graph, it wasn't a perfectly straight line. And that had to do with the fact that there was legislation that we put in place, things like Inflation Reduction Acts and other legislative measures to increase Medicare spending from the federal government. It's also really important to know that hospitals are diversifying their revenue. And so hospitals are not as dependent on incoming profits from healthcare services as they once were. So when you're told that you need to balance your spreadsheet, I think that that's a really funny thing that I hear a lot, and it's not realistic for what most services can provide if they're not providing procedures. And so I encourage genetic counselors who are having difficult conversations within their system to talk about these things and how you contribute to downstream revenue for procedures and for the things that are generating your health system revenue. I also encourage everyone to meter their non-clinical work. So if you're attending tumor boards, every single thing that you do, you should track as contributing to your health system, and you should do so in a way that is quantitative. Make sure that you're counting the number of hours that you spend and that you're tracking these things. There are aspects like revenue that can help. Certainly, any type of income stream that you can bring. But it wouldn't be a Brian talk if we didn't talk about genetic counselors should also bill. And so things that we're doing as a society are looking at increasing the RVUs for our own genetic counseling codes and really making sure that it's a priority as a field that we're talking to payers, having those conversations and establishing value. And with that.
Great. Okay, we'll get into the panel Q&A. I have some questions here. We have about 15 comments online. 14 of them are about the code. So it's 4719. It's listed in the comments, so you can scroll through and find it if you didn't write it down fast enough. But I will ask the first one that was on here, which actually I don't know the answer to. Maybe Brian does. If not, we will get back to folks and type a response in the session here. But it's, can you elaborate on how, or if at all, the Inflation Reduction Act might impact services we as genetic counselors provide to our patients?
So the Inflation Reduction Act is going to impact the Medicare conversion factor, so it will impact all services across the board. The idea is we would like to make sure that right now Medicare anticipates further reducing the conversion factor. So they're anticipating, I think it's going down like 3.4%. Actually, don't quote me on that, but to $32 instead of $33. And that sounds like a really small difference, but if you multiply it by the number of patients and services that you see, it just makes a huge difference. And so any services where you're billing a CPT code are impacted by the Medicare conversion factor, which is what they're looking to adjust.
Great, thank you. I think it's fine also for folks to go up to the mic here in this room if you're here live and have any questions. Kenny, I have a couple terminology questions for you to tackle. One of them is, first, when you say product market fit, what is that?
Yeah, so
No, you've got it.
very good question. I think it's obviously when you have an idea on building a product or services, you're hoping that somebody will be interested in using, adopting, or buying that. So you have an idea, and then you start building the product or services, and then you ultimately need to see in reality whether people are actually adopting and using that. So that's sort of the product market fit term.
Great. And then the other term that I think it'd be good to dive into a little bit is equity. We say that a lot, but what does that actually mean? How do folks balance that against salary and an employment offer? And what are the different types of equity?
Yeah, so in general, when I was talking about the letters of the alphabet and seed stage, so most of the time, the earlier the company's at, they don't have as much capital to give you a salary that's on par with a larger organization. So what they typically would tell you is the salary that they give you may be slightly lower than what's on market, compared to the professional status survey, for example. But in return, I'm going to give you some equity in hopes that this will actually be of significant value if you join the company and continue to build the value with us as a team. And typically, there are different types of equities, and there's these different acronyms. So RSUs is the restricted stock unit, where typically as the company progresses later on, that's what they give you. And that's basically stock that you would get. And typically there's a vesting schedule as well, over 4 years. There's also what they call the NSOs, the non-qualified stock options. Those are typically given to consultants rather than full-time employees because of tax. There's no tax incentives. But it's basically an option to purchase the stock, and you're hoping that the option to purchase it is actually at a much lower amount because the value of the company is not there yet. So you're getting at a significant discount. So the hope is that you will also benefit from that as well as the company progresses. And the last one that typically employees would get is the ISOs, or the incentive stock options. So there's incentive from a tax perspective if you actually acquire that earlier. But the mentality is the same compared to RSOs, NSOs as well.
Thank you. Great comment, reminder that Medicare does cover genetic counseling, but not when it's provided to by genetic counselors. So just a reminder to everyone to help with our efforts to get our federal bill passed so that can change. And we have a question here in the room.
Hi, I'm just wondering, where would we go to actually find jobs at startups? Like, how do we find those jobs?
Sorry, can you say that louder? Where do we go to see what?
Find jobs at startup companies.
Oh, okay.
Yeah, that's a very good question. So I think personally, my advice would be through networking, attending conferences like NSGC. There are many of us in the audience here that actually work at startups right now or historically has. I do think that's the best option rather than job postings that you would see or also on the web. All my jobs that I have received thus far are through networking. So that would be my advice.
I'm also on my third startup, and 100% of those jobs have been through networking, with the first one being from Kenny. But yeah, and also I think we're totally available to be connected with on LinkedIn or what have you, and if you have questions. Go ahead.
I have two questions. One first on the hospital networks. So we've seen a large increase in the number of hospital administrator roles. And I just wanted to get your take on that, because often it's being squeezed, it seems like, from people that are actually providing the care versus back-end billing and otherwise. And the second question was on new genetic treatments. Often we are now seeing a shift, at least from a funding perspective, away from cures into continuous treatment options. And I just want to get a take on that.
Good questions. All right, so first one, clinicians versus administrators, an age-old battle.
Yeah, so remember that health systems do largely mirror for-profit companies in the United States and their setup. And a typical way of managing finances within these systems is to hire administrators to look at costs and bring them down. So it's not remotely unusual when a hospital system is struggling to actually see consultants come in to advise the health system on where they can leverage or to see additional administrative burden. On the flip side, you can also see cuts in those areas. So it's relatively common when a hospital system is struggling to see middle management. But one of the things that I would encourage people at large not to take as a reassuring sign that things are well is things like bonuses. We tend to see bonuses, particularly in the current climate, regardless of whether or not a company is doing poorly or well. Shifts in the positions, who they're hiring, and if there are layoffs are much more indicative of the overall health of a company.
Yeah, and I don't know, maybe Christina, you want to address the question about the shift toward and what the impact maybe is, especially on publicly traded companies, pharmaceutical companies that have involvement in some of those either companion diagnostics or the actual genetic treatments themselves that are not one and done, but ongoing, very expensive treatments.
Yeah. I mean, certainly the diagnostic space right now increasingly is becoming more and more integrated and tied to the pharmaceutical, industry, given, precision medicine. In order to enable it, you need to be able to do the testing to, get that genomic information. And yeah, we have seen various new structures popping up. Instead of just getting clinical testing covered and having that test through the traditional ordering of genetic tests and getting that covered, we're now seeing different payment structures where the pharmaceutical companies are actually having a fee for service to labs to fund various clinical trials and get patients doing testing. Not sure if that necessarily answers the question, but
Yeah, hopefully that addressed it. But if the original questioner has a follow-up, please jump back in. So another question for you, Brian. Can you expand on how the conversion factor is adjusted for geographic location? Is there just a population consideration or demographic considerations? What goes into that?
It's like how we adjust salary for geographic location. So it's based on cost of living and metered out that way. It's a pretty small difference, but that is based on data that the federal government generally uses as companies. Like when we travel, they'll say you can spend this much in this city based on that type of thing. That's where the conversion factors geographic is adjusted. It's a small adjustment, but specifically in larger, more expensive cities, they'll get slightly larger payouts for services.
Okay, great. Christina, another question. You mentioned a lot of the great numbers to look at in terms of assessing the health of a publicly traded company. Where does somebody find that information, and how do you read those?
Yeah, a good place to start, as I mentioned, is the company's investors relations website. They often lay out a lot of the recent investor presentations, quarterly calls, quarterly reports, annual reports. So that's a good place to start. And what you can learn in terms of looking at it, first of all, look at the historical financial performance and some of the things that I mentioned of revenue growth, profitability metrics, cash, debt on hand. And but also you can understand it from a more operational standpoint of what is the management really highlighting to the investors when they're talking about it in the earnings calls. Earnings calls that you can either view them through the video or just search up the transcript. It's a quicker way to get to them, and you'll kind of see, what does the management really focus on in terms of the new product line, product launches, headways, challenges, and what they're really trying to prioritize. So it's helpful to kind of zoom out and think about it on a future standpoint, and rather than just the specific things that you may be focusing on a more day-to-day basis.
And so, and the publicly traded companies are required to issue a quarterly report. So that's part of the benefits and potential drawbacks of being a public company is you got to lay it all out there every quarter and everyone can see. The other thing I like to look at is the what questions. So the company will give their presentation. They have a very detailed report, which Christina loves to read, but I don't. But the company will do a presentation which shows you what their narrative is and what their plans are and what they perceive as their challenges. But then you also get to hear what investors are asking them, like analysts and real experts in the area. And that can kind of uncover some of the maybe holes or gaps in that narrative that you're hearing. So it's just another little way to learn a little bit more. We have a question over here.
I do. Brian, when you're doing the RVU calculation, is it correct to assume that with the new bill for Medicare acknowledgement that RVU would go up because that you would see something in the provider line, correct? Okay, that's what I was thinking. So with that being a potential increase in healthcare, if we see that provider status improved in that sector, do we anticipate a change in industry when we're talking about salaries for genetic counselors in those roles as well?
Oh, I love this question. I think I'm going to answer a few things. Yes, absolutely. One of the things we want to see as a field is we want to add provider work and change that zero. We'd also love to get liability insurance covered under a CPT code for gen counselors. We are actively already working in the space that we can to improve that middle line as a society, that practice expense. And so we're working to update the code to make it better for genetic counselors. But in the meantime, that's the only thing that we can do without Medicare recognition. For the second part with salaries, I think the one thing that I'm frequently, my own team can tell you, is that as a field, we have to at some point reconcile the fact that we cannot make more than the other fields around us and provide services that they can do with similar or equivalent degrees. So at least I'm speaking from my own experience when I joined the field several years ago. My salary has increased quite a bit, but I think we are going to hit a ceiling, at least clinically, when we start to approach other specialties like PAs and NPs. If someone can perform genetic counseling as a non-genetic counselor and make more and make less money than genetic counselors, hospitals will start to see that as a problem. And so I do anticipate that at some point we'll start to see a leveling clinically, but at any time we see increases in clinical work, we'll see increases in industry. More importantly, I actually think is that once we can justify genetic counselor positions at hospitals, hospitals support industry, right? Hospitals are both a supplier and someone that purchases. And when we look at statistics, hospitals that use genetic counselors are more compliant with NCCN recommendations for genetic testing, which brings more money to industry. And so I think that generally speaking, having Medicare recognition will certainly be favorable for both clinical and industry.
Here's a related question for industry. One of the issues that companies face is the lack of reimbursement from insurance payers for the company's products, such as genetic testing. What can be done to accelerate more successful reimbursement? Want to take that one, Kenny? You have direct work.
Yeah. For context, I was involved in creating the CPT code for expanded carrier screening to try to drive reimbursement. So I think, the question was, how do we accelerate the adoption?
How do we accelerate more successful reimbursement? Yeah.
I think it's hard because there's a multi-pronged approach. Even I no longer have a conflict of interest in carrier screening or whatsoever. Still not being covered most of the time because you need guidelines to adopt it. Then you also need medical policies to change as well. And the reality is, at least from my knowledge for women's health, payers are still not covering for next generation sequencing for cystic fibrosis. And I assume most of the people clinically are offering that as status quo. So I think it is hard. I think it is a multi-pronged approach where the first thing is to actually, as a society, agree to change guidelines from the general practitioners. So in this case, for women's health, it would be ACOG that we need to work together as a team to really change that and then work on changing medical policy to go from there.
Something I've also been thinking about recently is this idea of bringing more value-based testing, in the sense that right now reimbursement for genetic testing and diagnostics in general is based on the cost of the price is based on connected to the cost of running the test itself, and not necessarily the value that it creates for patients and payers potentially. And if you think about drug development and the pharmaceutical industry, that's completely different, right? Like the analogy would be like if you had drugs, then like if it was reimbursed the same way that diagnostics is, then the equivalent would be like the price would be based on the cost of manufacturing the drugs, which we all know that is not the case, right? So yeah, it's something that I've been thinking about, is how can we change that? But certainly that's an overhaul of the entire reimbursement system, which won't happen overnight.
Jillian?
This question, I think, is for Brian. Could you comment on how pricing for counseling services is working in the Medicaid sector? And I know in a lot of places it's not working at all. So if we just sort of limited it down to the places where maybe it is working, and how it's working in sort of more of the like traditional state Medicaid programs, where I imagine they're working off of a standard fee schedule and somehow adopting the CMS rate, and then the like managed care organizations, where my gut tells me it's probably more likely to be based on contracts between those managed care organizations, who may also be deferring to CMS. But if you have a sense of
Jillian,
that,
you just answered the question.
I was guessing. I don't know anything about it.
Y'all, my dream actually for us to consider as a society is I would love for us to get a list of all the state Medicaids that cover 96040 and the ones that don't. I think that we could actively be writing letters to some Medicaids to say, hey, cover us even in the absence of federal recognition. And we have precedent for this. The state of New York and the gen counselors there have been trying so long for licensure, but they're covered by Medicaid. And how wild is, and wonderful in that particular sense. Medicaids are so complicated, Jillian, and in that they are run by the state. They are part of CMS, but they are given state-dependent permission to run their own programs. And when it comes to pricing, they are not beholden to those Medicare minimums. And in fact, it's very typical for Medicaids to pay well below the Medicare minimum. Medicaid is really meant as a safety net program to protect people that really don't have otherwise have access to services. So it's really intended for a lot of pediatric cases or specific disabilities that qualify. And it's quite normal for Medicaid to even cover about 1/100th or a penny on the dollar for what Medicare does. Generally, that's allowable through the laws that establish Medicaid in a particular state. And when it comes to this particular Medicaid, like the pure Medicaid that each state pays, that's going to be their typical, that just whatever the allowance is in the state of what the discount is from the Medicare program, if they follow Medicare, will be just what you see. And the likelihood that you're going to get anything more than that it's not going to be strong. For the managed plans, with all managed plans, they're really allowed to scale beyond that, and they typically do so based on a contracting. basis. And in that space, we see a lot of success for pediatric hospitals. We've talked about this before, Jillian, and that they have a lot of negotiating power in a particular geographic area. Pediatric hospital may be the only catchment center that a family can receive services at. And so they often are more beholden to negotiations with pediatric centers regarding the cost of services. I hope that answered your question.
Great. Ashley?
Thank you so much for the great presentation. Brian, I would love to share my resources on Medicaid. So I want to address the question that Kenny got about improving reimbursement for genetic testing. So we can't write the guidelines unless we have the evidence. So my plug here for everyone listening is that we need non-industry authored evidence showing that genetic counseling and genetic testing improves health outcomes. So we have great evidence being published by industry, but we need more of that from the academic centers.
Well said, yes. Here's a great question online. Given all the financial issues currently facing healthcare systems, do you have any advice on how to get help from administration for billing for genetic counseling services when they have other possibly more profitable departments with issues to address?
You know, I do. I hear a lot of pain from genetic counselors in this area. And one of the things to talk about is allowances that you can make in billing. And what I mean by that is billing is much more open-ended than you might think. I think we have this tendency to say, if we charge for a product and the payer doesn't pay it, then we need to balance bill the patient. But within a health system, there is a lot of flexibility and gray area in that space, and what the hospital system does when a payer doesn't fully reimburse them. And so one thing for practices to engage in a conversation with their billing department in is, can we try billing, and within the bounds that we have within our contracts, within our payer relations, can we set up a system where if we're getting denials, we're not balance billing the patient, but instead pursuing contracts based on those denials with the payer to create essentially a negotiation platform to say, hey, you're not being competitive in the marketplace with all these other payers who are providing services. And this is where getting in touch with your payer relations team, the people that do the contracting with the payers at your health system, can be really powerful. They can help you connect with the health plans and identify why you're not getting coverage. A lot of times I find that it's not a problem with covering 96040, it's a problem with contracting genetic counselors. They don't recognize genetic counselors on the plan because Medicare doesn't recognize genetic counselors. But you do not need Medicare recognition to contract genetic counselors. We have certification. There are ways to verify credentials for genetic counselors that are independent of Medicare. And you can provide them with examples. United Healthcare, Aetna, all contract genetic counselors and are competitors in that space. So emphasizing the competition to payers and having a conversation with your billing department about setting up billing so that it doesn't devastate your patient relationship is, I think, a really strong way to start.
It is a bit of a chicken and an egg. You can't go to an insurance company and contract for services if they don't see any evidence of demand. So you have to be billing for it to demonstrate that demand. Otherwise, they're gonna be like, we don't need to contract for this. There's no demand for it. So you do need to start with that first, yeah. I think this question is a good one for you, Christina, based on some of your experiences. Can you speak to the increasing trends of GCs setting up independent practices and whether that helps in the macroeconomic sense to improve genetic counselors' value in the current market?
That's an interesting question. I think certainly, yeah, it does. I mean, one of the things that's on top of mind for me, given these recent disruptions within the commercial genetic testing labs, is increasingly genetic counseling services have become integrally tied to these commercial labs, given that a lot of lab GCs do offer genetic counseling services as part of the tests. So if there are disruptions within the industry and lab, then that can disrupt and impact access to clinical expertise within to patients and providers if there are restructurings and layoffs within the labs. So yeah, I mean, one way is potentially having GC set up their own independent practices and try to help with serving and meeting the patients and demand in a way that was not previously served. I spent part of my time in a private practice at Advocate, and we focused on a specific niche, which is providing genetic counseling services for patients seeking fertility treatment, so like IVF, and that is a pretty niche space. It's also for telecounseling services. So yeah, finding niches where you have the expertise and can be able to offer that is certainly can be helpful.
Go ahead.
Hi, Julie Cohen from Kennedy Krieger. I'm a clinician and director of clinical genetic counseling services there. So I have a request and two questions. A request is next year, we need an entire session or workshop on understanding billing for genetic counseling and tools for genetic counselors to advocate within their institute to establish billing. I'm going to
Sounds like a great submission.
Yeah. All right. I'm going to regret it later. I volunteered to participate in that. I'm not going to be in charge of it, but I'll participate. Okay. And then my two questions are, Brian, how did you get so knowledgeable about about like CPT codes and all that stuff and all that stuff? And what, I know NSGC has some resources on their website, but maybe you could plug that and other resources to understand in more depth about billing for genetic counseling, CPT codes, and all of the topics you're presenting, because we're not business people, but we need to be business savvy.
Yeah, so if you haven't met my boss, Sarah Pierzadeh-Miller, she was just recently elected to president-elect, and she's an incredible person to work with and for. I oversaw the scheduling team at UT Southwestern back in 2019 when we decided in an unlicensed state to go from having never billed before for our services to bill for our service line. And we're a huge program. We have 6 hospital systems. It was, Sarah was the most incredible person because I was a disaster. I was like, why are we doing this? Everything's gonna be the worst. We're just gonna show them we can't make any money and then we're all gonna get fired. I kid you not. So dramatic. None of that happened, y'all. None of that happened. It turns out we don't turn a profit. We have 19 genetic counselors in our oncology practice. We do bill for services in an unlicensed state. There's plenty of payers that do not reimburse us. But I have learned through that process of helping establish the value for what we were going to charge. So we were talking about value, but you can set your own value and then negotiate it with payers. You don't have to use that Medicare minimum. And so through that process, we had to go and argue for what we thought the value of the service should be. We had to talk about billing forms. Do you use the institutional billing form or do you use the professional fee billing form and all those things. It was a wealth of experience through lived hurt. So I attribute that to my learning, and then I've been really heavily involved in the society and working toward improving valuation for our CPT code, which has been a wealth of experience.
Thank you. Question for Kenny or Christina, or I guess I can answer this too. What percentage of the time, very specific, but I guess just generally, how often do you feel that interactions with business-focused staff, that they are pushing for compromises that you, from a clinical perspective, have less comfort with? And as a clinical GC, this is a concern when thinking about a move into that space. Just curious. Okay. Does that come up? How do you navigate that? Is that ever a true conflict between a clinical product and profit or business efforts?
Trying to think overall, based on my experience in the last 3 startups that I've been in, I think On a high level, the answer is no, but I think they don't understand the nuance of the impact of what they're proposing on the impact to the patients. But I do think a lot of times they don't understand the impact, so you always have to explain to them, well, if you actually are proposing this, yes, we may increase market share, but this is the impact to the patients. But when you explain that to them, though, they do agree. So I think it's more just increasing the understanding for them based on your clinical experience.
Yeah, it's one of the reasons I actually think having clinicians in roles that interact or are responsible for profit and loss and product development, things like that is really good because you can bring that lens to that development process from the get-go. And generally, good clinical care is better business because that's who we're trying to build products for and services for are for either the clinicians or the patients that they serve. So just try and keep that front and center. I myself haven't had an experience where I've felt compromised, but I have had experiences where I needed to say something and I felt listened to. More to add to that, Chris?
I mean, broadly speaking, I think one of the things for early stage diagnostics development is that there's a tendency to focus a lot on the technical challenges of like biomarker discovery, assay development, analytical validity, sample processing, which are all very critical, important things. Don't get me wrong, but I think it should not come at the expense of not thinking about like the market facing needs, just like the basic, like, so what of the test, like who cares about this impact, who will pay for it. And so those very basic questions shouldn't be overlooked. And so, yeah, I mean, that's a example where the clinical side and the commercial and sales side can really work together to find those answers and balance those two things.
Yeah, and I think going back to what Kenny said during his portion of the talk where you're looking at the kind of the mission and the vision and aligning with folks that you feel good working with is a big thing. All right, is there nobody in the room right now? I wanted to ask another question as we're getting toward the end here for each of you to answer. What do you think is the most important message for genetic counselors in training to know?
Let me just.
Sure, go for it.
So I think if I could rewind back to the 16 or 17 years ago when I was in Sarah Lawrence, was really knowing that we do have the skill sets that we need, that we've learned as a student, and also if you do end up going to clinical practice for a few years, we do have the skill set needed to do what we want to do in the healthcare landscape, whether you want to go into product management, program management, variant curation, and whatnot. 16 or 17 years ago, I've always looked into, well, what I have learned is not enough. Maybe I should go back into school. In the last decade or so, I've definitely learned that we do have the skill sets needed to really relay complex information in a concise manner for a very good narrative for early startups, to tell the right story to investors. So that's what I wished I would have known back then.
Yeah, I haven't been out for very long. So if I were to rewind just 2 years, I would say, yeah, just continue to keep an open mind to future possibilities, opportunities, to always be constantly learning. The world outside of the clinical genetic counseling that we have trained in our clinical rotations is very large. And there's a lot of different opportunities and problems to be solved beyond just what we see in the clinic within our clinical training. So would encourage to think big and broad, to understand that there are a lot of different components to the healthcare industry to be cognizant and aware of, but also humble to say that I don't know everything, and that's okay. And I'm just continue to learn and evolve and grow and evolve my mindset. I may be wrong sometimes, but hopefully the goal is that I'll be wrong less often over time.
And someone shouted bill for services. I think I would adjust that slightly to, I hear a lot of people say like, oh, why do we have to talk about these things? I just want to see my patients. I just want to care about healthcare. And when you look at the primary stressors for the majority of Americans, finances is one of the most consistently top stressors that patients and families experience. And it is certainly exacerbated by their healthcare experience. I do not think that you can be a well-rounded genetic counselor and ignore the financial stressors that your patients are experiencing. And so one thing I would really want students to take away is that you don't have to be perfect at understanding the healthcare spectrum to be a good advocate for your patients and helping them understand healthcare. So even knowing fundamentals like understanding what a deductible is, coinsurance and copay, understanding why it might not be an excellent idea for a patient with a chronic condition to have a high deductible health plan when the recommendations that you're providing might include things like significant screens once a year, can be really beneficial to helping the family understand how to start managing some of their key stressors. So I think one of the things I'd like students to take away is that finances is interwoven with healthcare, whether or not we want it, but it's also interwoven with the feelings that our patients have, the anxieties that they're bringing to our session. And I don't think that we can use the argument that, oh, because physicians don't have to care about it, we don't, because we're not physicians, we're genetic counselors. And I think it's a key part of what we do.
Hear, hear. Yeah, and I would, just to piggyback on what Brian was saying, I would say especially for students, if you can get really knowledgeable and comfortable with your own insurance care and your own engagement as a patient with the healthcare system, that will help you learn a lot about how things work, about how a deductible works and things like that too. So being a good self-advocate and knowledgeable about your own situation can teach you a lot. And you can also do things like looking at, what investments the university that you're at or the hospital system that you're rotating at, they usually have reports available on their websites. You can see where are they investing things, what is their strategic vision, and things like that. So just spending a little more time to look at the full picture is good advice. All right. Oh, I'm sorry, I didn't see you. Please go ahead.
Hi, Shauna White. First, I wanted to sincerely thank the four of you for what you've shared today. A lot of those lessons I bet many of us have learned the hard way by running into barriers, at least in my past decade, and I learned so much new information. So I really appreciate that.
Thank you.
I'm someone who recently transitioned into more of a startup or early role, and I did it through a network just by coincidence, and then getting into the interview and thinking, what the heck questions do I ask? And actually, it was a student of mine who really helped mentor me and then connected me with Carrie. So thank you, because some of those questions I used, and there's so many more that I wish I'd asked that I want to ask next time. And so I was curious for the folks up there, how did you even learn or start to find answers to some of the questions there? Where did you gain this knowledge, and how can we continue to learn? And is it by having conversations, these kinds of discussions, or are there other resources online we should be considering?
Yeah, we've gotten a lot of questions about resources. For myself, it really started with just talking to people. I loved my patient care roles and my team, and I never was burnt out on that aspect of it. I was a little burnt out on the bureaucracy part of things and wanted to have a bigger impact. And so I just started talking to folks that I knew in my network who were not in traditional genetic counseling roles. One of them was Kenny. And I also was looking specifically at talking to the companies of the products that I used in the clinic with my patients and that I liked or didn't like, and was like, how does this happen and how can I make it better, and that sort of thing. So I think starting with what you know is always a good place, and that includes who you know. So that's my piece on that in terms of resources. But we have had a lot of questions about where can we learn more about the language of healthcare systems and so on and so forth. So any online resources or other things we can talk about now and add to the chat too later as we think of them.
Yeah, I think for me, to echo your comments as well, it was through talking to also folks that work in startup, like Alyssa Levine, who's also here as well. I talked to her many years ago when I was considering joining my first startup. I think related to the next session as well, ChatGPT and stuff is also very helpful in sort of finding general information that are things you should consider in addition to, I think, networking and talking to folks that are in startups. I think the one thing I would definitely advise you in learning through my own mistakes is also, given we're a very tight community, which is great, I think you can also, as they share compensation packages with you, to seek advice from colleagues that are in startup space to give you a sense in terms of, oh, is this actually something that's similar to what's being offered elsewhere at a similar stage company as well. And there are online resources for that as well that you can find in ChatGPT and Google Bard as well.
Little plug for the next late-breaking session.
So, I mean, I think the question overall is more about, like, how did we... I think the benefit of knowledge that it's accumulative, right? So, like, it is a matter of time and the more connections that you make, both in terms of the people that you talk to and the conversations that you have, and also the things that you come across and that you read, they accumulate over time. So it creates this sort of like web of things in your mind and connections. And I mean, personally, I started getting more into the finance side and trying to understand a little bit more, just because I realized that it's such a critical component to access and delivery and the impact that it has on patients. So I just started reading a lot. And a lot of times there can be a lot of good state of the art, like state of the union, like reports on certain industries, or a lot of times the companies will have really good presentations, and so personally, I've just consumed a lot of information, and then when talking to people, I think a helpful way is to follow the breadcrumbs of, once you talk with someone, you can say, "Oh, this is really interesting. Who else can I talk to about X, Y, Z?" And you can go from there. And so the conversations don't just end with that one person that you're talking to.
Christina's also done a great job sharing a lot of knowledge with her newsletter called Health and Wealth. So you can look that up. I think those are informative articles as well.
If you're at a hospital system, my advice is to find the person that runs the spreadsheets. Every hospital system has someone whose job it is to run all the spreadsheets for the higher ups at the hospital system, because doing that is a painful job. That person tends to know everything. And particularly, I think I worry about barriers being like middle management saying like, oh, you don't need to attend these finance meetings, like go see patients. And if that's the case, I would encourage you to add to your goals in the conversations with them to get you in on those conversations with the finance team that reviews your department spreadsheets and talks about revenue for the hospital, because just sitting in those quarterly is a wealth of information, and those people that run the spreadsheets for the hospitals can really tell you better than anyone the financial health of the hospital, where the system is doing well, where the pain points are, and it can help you be much more aware of what's going on.
Yeah, great. Thank you so much. I think that will wrap it up for us. I didn't leave anyone at the mic, so I appreciate this. I think all of us are open for contact, and we'll be around during the break if anyone has additional questions. Enjoy the rest of the conference. Thank you.